Sudhir? Mr. Sudhir?
Yes, ma'am.
I hope we will start on time.
Yeah, ma'am. Just Dr. Adarsh is there, Dr. Monica is there, Dr. KP Sinha is already joined, ma'am.
So I think if we have most of the audience, I am here, we are all together, I think we should begin. Why should we? It's already 8 p.m. You can take that consensus too. We can't hear you, Dr. Monica.
Mute. How are you doing?
Very well, very well. Aap kaise ho?
All good.
I would think we should begin. What do you think?
Yeah, let's go ahead.
So, Dr. Monica, let's hear from you what's happening to COVID.
Cases are increasing because obviously, one, the variants are coming in, and people have unmasked totally 200%.
Right.
So, but fortunately, most of the cases at the moment are mild. I haven't required to admit any of them. I haven't really required any CT scans or steroids kind of thing, but too early to say because last 10 days, wherein I would see 1 or 2 cases in a week, now I'm practically seeing 5 to 10 cases in a day. But most of these people are actually not even being counted in the census because they're all doing rapid tests at home. So the data that you're getting from the RT-PCRs is just 1/10 of the actual numbers because most people are only doing rapids. They are not even doing an RT-PCR.
And the symptomatic status is the same. It's URI.
Mild. Let's keep our fingers crossed because middle of May is when it is supposed to be rising. And already with malaria, dengue, typhoid, then it will be a difficult task to guess what's happening to whom.
I couldn't agree more. Mr. Sudhir, do you want me to share my screen?
Yes, ma'am. I think we should start.
I would think so. Let's start. So I'll share my screen. Is it visible?
Yes, ma'am. It's visible. Fine.
So are you going to do the introductions at the beginning?
Yes, ma'am.
Yeah, sure.
So, good evening to all. I'm Rohit Bansal, based at Delhi. I'm working as a journal head for the CIPLA, for the cardiac division. This is the new initiative has taken by the CIPLA for the strengthening heart expert meeting, which is based upon the MRI in the heart failure. And now today we have with us Dr. Aparna Jaswal, very well-known speaker in the and doing the practice with the Fortis Hospital in New Delhi at Department of as a additional director of cardiology, Department of Cardiac Pacing and Electrophysiology in the Fortis Hospital, New Delhi. Ma'am is having the fellowship of the Heart Rhythm Society USA and the fellow of ACC. With the ma'am is having the certified cardiac device specialist. And today, ma'am, we have with us with the expert panelist with Dr. Monica Mahajan, along with Dr. Praveen Kulsesta, with Dr. Dhananjay Kumar, along with Dr. Kanwar Singh, Dr. S.P. Kalra, Dr. Adarsh Kumar as a senior cardiologist, cardiophysician, and Dr. K.P. Sinha doing the cardiophysician practice with the Jeevan Hospital, Delhi. So all the expert panelists are from South Delhi only today. And this session will be fully interactive along with your wonderful presentation. With the start with the presentation, the flow with the event will be, you will start with a small presentation map and then the open house for all the expert panelists so that we can do one interaction. And I'm requesting to all the expert panelists, please make attentive in the session and make this successful for the, on the scientific platform so that all can be get the benefit of the program. So over to you, ma'am.
Thank you so much, Mr. Rohit, for this opportunity, and I thank all the panelists that we're together here, and I think all of us in the end of this program will see how we are practicing, what are the challenges we face, so as to increase the penetration of guideline medical therapy. So we chose this topic of mineralocorticoid receptor antagonists in heart failure, and as Mr. Rohit has spoken to you about the agenda, we'll try and keep it interactive as best as we can, and we shall close it on time. So as we already mentioned, I think today we are together to speak of a molecule which has remained an unsung hero. The reason I say it's been an unsung hero is because I think we're well aware of the newer kids on the block stealing all the space, be it ARNI or be it SGLT2 inhibitors. I think it is time we began to spoke of this. This is a molecule which is unique. I will take you and walk you through in the next few slides. So where is its placement in utilization in heart failure management? Hyperkalemia, what is the concern in our clinical practice? And of course, as I said, it is an unsung hero. It's time we give its due importance, and I thank CIPLA for taking this opportunity to bring this molecule forward so that we all together increase the prescription of this molecule, which actually has shown to reduce cardiovascular morbidity, mortality, as well as heart failure hospitalizations. I thank the entire advisory panel, as Mr. Rohit mentioned, and without taking much time, I think I wish to speak on the topic here. If you just give me a moment. I thought my fan is very noisy, so I'll just switch it off. So global epidemiology of heart failure. I think we are well aware that 1 to 2% of adult population with heart failure in developed countries is suffering. It's interesting to note that those individuals or the population which is less than 50, the prevalence of heart failure is 1%, but as we age, beyond 70 years of age, the prevalence increases to as high as 10%. It's important we talk about this because there's something unique to India. The sheer burden of cardiovascular disease in India is extremely large. I think I have a very august audience gathering here who know about the prevalence of diabetes, hypertension, CAD, all of them together making the prevalence of heart failure much more aggressive and dominant in our country. It's important we discuss this, and I'll take you through few of these latest terminologies simply because it will be good for us to revise. Much has changed in heart failure from the time that we were medical students. Heart failure today has been described into 3 parts, especially on the basis of phenotype. And this is from the European guidelines of 2021. So we have HFrEF, which we are much aware, when the ejection fraction is less than or equal to 40%. We have heart failure, mildly reduced ejection fraction, when the EF is 41 to 49, and HFpEF, when the ejection fraction is equal to or more than 50%. It's important to make a point here that a lot of attention is now being directed towards HFpEF. However, you must diagnose HFpEF if the patient has symptoms along with signs and has an objective evidence of cardiac structural and or functional abnormalities and or raised natriuretic peptides. I am sure all of us are well aware that in 2020, recently we have the newer guidelines from the Heart Failure Society of America, the ACC-AHA, on heart failure again. So if you look to the left, that's exactly what I said. HFrEF, heart failure, mildly reduced ejection fraction. Let me make a mention here. It was earlier called mid-range, but now we don't call it mid-range. We say mildly reduced EF, and HFpEF is with preserved EF. On the right, what you see is what we all understand, that heart failure is a dynamic problem. If you diagnose a HFpEF today, he may progress to HFrEF. So what is your initial classification and what is your reclassification must continue as you see your patients in follow-up. It's important to make a point here that we must utilize this NYHA classification when we see our patients so that you have an objective indicator as to how he's going. So class 1 is no limitation of physical activity. Class 2 is slight limitation of physical activity. Class 3, marked limitation, and class 4 is unable to carry on any physical activity without discomfort. We are much aware about the recommended diagnostic tests in 2022 for patients with suspected heart failure. BNP and NT-proBNP. Few years ago, we were not utilizing it as much, but today we significantly have the utilization of this BNP and NT-proBNP. You must remember a value of BNP less than 35, NT-proBNP less than 125 makes heart failure extremely unlikely. You would like to do a 12-lead ECG, an echocardiogram, an X-ray, and of course, all routine blood tests along with ferritin and the saturation, transferrin saturation. Whenever you see a patient who has suspected heart failure, you have a clinical history and physical examination with ECG and labs. Quickly, you do natriuretic peptides. If these values are less than this, it makes heart failure very unlikely. And then you do a transthoracic echo, and subsequent of transthoracic echo, you are then able to give the phenotypic classification of HFrEF, HFpEF, or heart failure, mildly reduced ejection fraction, and subsequently initiate the treatment. This is from the 2022 guidelines that we have. So I think I'd like to stop here for a few minutes and seek your thoughts. In what percentage of heart failure patients approach you? At what stage are they of NYHA functional class? And what do you think? How many of them actually go undiagnosed? And what are the diagnostic and prognostic tools? We've mentioned a few here in the presentation, but what do you think are the diagnostic and prognostic tools used for heart failure patients in your clinical practice? So I think I open the house and maybe we can have 1 or 2 people come in, please, and give their thoughts that in their clinical practice, what is the percentage of patients in different stages that you see?
So Aparna, in my practice, I practically see all NYHA stages of patients, and again, all the 3 phenotypes as far as the patients are concerned. And a lot of times these people have been wrongly labeled as asthma or COPD, and they are misdiagnosed as suffering from respiratory causes of breathlessness rather than in terms of being evaluated for heart failure. And we have both varieties, in fact, of HFrEF as well as HFpEF coming to the medicine OPD, and a lot of times being misdiagnosed totally in terms of either asthma, COPD, or an overlap without even being ever tested for an NT-proBNP or in terms of echos being ordered. And again, if we remember from our medical college days, it's so easy to diagnose heart failure, especially in a chronic heart failure patient. You look at the JVP, pedal edema, look at the cardiac impulse and the heart sounds, and practically half your job is already done. But most people, unfortunately, are being not diagnosed rather than, and some of them misdiagnosed as respiratory causes of breathlessness. And the second part is in terms of, again, the diagnostic tools. In India, per se, echocardiography is now so easily available. BNP and NT-proBNP, again, most of the bigger labs are doing, even if they are not doing in smaller cities, at least in the metropolitan cities, this blood test is easily available. The only issue is that between the ESC guidelines that are now recommending that you do the BNP and the NT-proBNP first and the echo as a second stage recommendation, I think in India, the number of echo machines is much more compared to the labs that are doing NT-proBNP. So in our country, it's easier to straight away do a echo for diagnosis and doing the NT-proBNP for prognostication. So that makes better sense that at least you establish the diagnosis by doing the echo, and then you can do the NT-proBNP to prognosticate the patient as to how bad the long-term situation is. And again, in terms of the rest of the tests for comorbidities are easily available in all the hospitals and all the clinics. So again, whenever there is a diagnosis of heart failure, I think it's very important to look for anemia, look for thyroid disorders and so on and so forth. And especially at least look at the HbA1c with the burden of diabetes that we have in our country. So late diagnosis, misdiagnosis, and then underutilization of the available investigations. That's the challenge that we have at the moment.
Absolutely. I think you put it so very well, and that's a reality. Dr. Adarsh, sir, would you like to come in?
See, mostly we see the patient with a low ejection fraction, and they come to us with an NYHA class of class 3 and class 4. So they have a comorbid condition which has resulted in the condition of the low EF and NYHA class 3. And when they are investigated, they are being treated, but they are being treated inadequately. Or maybe the comorbid conditions are not being taken into consideration. So inadequate treatment of hypertension, inadequate treatment of the diabetes, and maybe they are taking some NSAIDs which are precipitating the heart failure. So most probably it is a combination, overall combination, their mental health, not only physical, but mental health also. Half of them are not sleeping in the night, so insomnia is there. So I think it's not a simple matter of EF. It's a matter of comprehensive looking at all the body parts. So I would like to treat all the parts because I'm an internist. I would like to treat all the parts and then take into consideration the heart condition.
I completely agree with you. I think those who have put so pertinent points, and moving forward from there, I think we want to take it forward, and we are well aware that just as atrial fibrillation, I always make this a mention, that in atrial fibrillation, in the past decade, we've had a dozen updates. Similarly, in heart failure, in the past decade, we've had at least 7 to 9 updates. So this is the 2021 update, which tells us that the treatment algorithm for guideline-directed medical therapy, including novel therapy. So I think all of us are aware that when we have HFrEF, choice of drug is ARNI. If ARNI cannot be given, then of course ACAR with beta blocker and diuretic. And you can see on the left, the first box, which says that for patients who have a GFR of more than 30 or a creatinine less than 2.5 and a potassium less than or equal to 5, we must add aldosterone antagonist. So I think this is the point that I wanted to make up here, that the guidelines are very clear and categorical, be it ACC-AHA, be it 2021 ESC guidelines, all of them put forth the foundational 4. The foundational 4 being ARNI, beta blockers, MRA, and SGLT2 inhibitors. However, we need to focus today on MRA because we do realize that this prescription, this molecule has not had its entry at its best over these years, despite having resounding data on its side. So I told you the ACC 2021, the ESC 2021, and this is from the ACC-AHA HFSA 2022. So step 1, when you see a HFrEF, if 40% or less, the molecules which you need to bring on board, we will discuss in the next few minutes as to how do we do that, are ARNI, beta blockers, MRA, SGLT2 inhibitors. Thus, we conclude those patients who are in HFrEF, MRA is class 1. Those who are in heart failure, mildly reduced ejection fraction, MRA is class 2B. As I just mentioned, the 4 pillars of heart failure, and we will discuss about how to bring them on board. We very well know the prescription of a heart failure patient, if he's in HFrEF, is surely incomplete if we have not been able to establish the entry of ARNI, beta blockers, MRA, and SGLT2 inhibitors. However, what brings us to the pertinent point of discussion is when are we to be cautious when we are using MRAs? Serum potassium concentration equal to or more than 5, severe renal impairment, eGFR less than 30, or a creat more than 2.5 in men and more than 2 in women. So I want to again open the house as to, in your clinical practice, when you see a patient of heart failure, what is it that you do as far as KFT is concerned, potassium level is concerned, eGFR is concerned, not only before initiating MRAs and the frequency, but also when you want to initiate other molecules such as RNA, SGLT2 inhibitors. So what's your clinical practice? I think we'll open the house for discussion here, please. Anyone can just jump in. So I think,
hello.
Yeah, Dr. Praveen, please.
Yeah. So the most important thing is to see whether what is the potassium level and the echo findings. The ejection fraction is most important thing to start with the MRA.
Yeah, I think we lost him.
Because it's a class such kinds of heart failure.
With an EGFR which is less than 30, then we can't be using.
First thing is start with the ARNIs and beta blocker. The maximum level beta blocker has to be used.
I think Rohit, you'll have to help sir with
then
his.
We can add on to the MS.
So I think,
and then we can add the as a fourth drug SGLT2. Okay.
So, yeah, perfect.
And the most important thing is to see with the BNP, important tool to diagnose with the heart failure.
Absolutely. So I think it goes without saying today that when we see our patients, not
so
only
we look
in heart
for these
failure,
tests.
Yeah. So not only in heart failure, be it atrial fibrillation, and I think those of you who are internists practicing the ICU, like Dr. Monica, she'll agree, they are so dynamic. Every time the patient walks in, you want to make sure what is his GFR level. So today, it's like I've realized that when you write a prescription, just as you write the patient's name, blood pressure, sex, you have to write an eGFR. Without knowing an eGFR, you are not able to prescribe significant number of medications, which was not practiced in the past. We've also realized that they're dynamic.
Yes.
Whenever we are seeing a patient of heart failure, it goes without saying that we have to categorize what is the patient's GFR and what is the patient's potassium. And it is not one odd time. I think, as I mentioned, and as previous speakers have been speaking, they are dynamic, and we like to keep repeating them and seeing how they are. So this is from the latest guidelines of 2022. And this is what they say. The class of recommendation is one with level of evidence A, that in patients with HFrEF, with symptomatic heart failure, MRA is recommended in patients with GFR more than 30, potassium less than 5. Clearly it writes, careful monitoring of potassium, renal function, diuretic dosing should be performed at initiation and closely monitored thereafter. How often is answered here. Regular checks of serum potassium levels should be performed approximately after 1 week of initiation, then 4 weeks of initiation, and every 6 months. We also make a mention, as you read within the lines, that those of our patients who have compromised GFRs, you may want to continue checking them, not at 6 months, but every 2 to 3 months. That answers it, which brings us to the most pertinent question of today's evening. In your practice, how often are you able to bring MRAs on board? And do you consider starting MRAs in patients along with ASARB, ARNI, and beta blockers? Or do you think you want to position them later? I think this is important. What percentage of your patients are you keen on bringing MRAs on board? So I think anyone can just come in. So I think we have realized that MRA is an essential foundational 4. It has to make its entry. No prescription is complete unless you have all the foundational 4s, unless there is some compelling reason for you not to have them on. But I think what's most important is question number 5. When do you consider starting MRAs? So now I think Dr. Praveen did try to answer that, but there were some connection issues. So let me try and make it a bit simpler. So whenever you see a patient of HFrEF, I think it's important to understand, is he wet or is he dry? If your patient is wet and congested, You realize this is a patient that I want to give him optimal loop diuretics, dry him, and bring on board ARNI, provided the patient's GFR, blood pressure, and potassium allow you to bring on board ARNI. So you want to give the molecule ARNI and make its entry. At the same time, if you have another patient who has heart failure and is dry, that's a point that you may want to start with the beta block. If the patient is having fragile hemodynamics, blood pressure is say 100, 110, you want to bring beta blockers on board. You don't have to wait too long. It's very clear. We've all understood the waiting period in bringing these foundational 4 on board is 4 weeks. If you have a heart failure patient whose potassium is high, you may want to actually start with SGLT2 inhibitors and bring ARNI later. So it's nothing like I would want to give one molecule, up titrate the dose to maximum, and then bring the other molecule on board. You have to understand that you would like to bring all of them on board, and now more and more guidelines are saying that we would like to bring them all within 6 weeks. So I think when your patient is wet, start the patient with ACE inhibitor, loop diuretics, and add MRA. Consider beta blockers and SGLT2 as time goes by. If your patient is completely dry, you can bring beta blockers and ARNI together and then add MRA. If you select for any index patient that I want to start with MRA early because he's hypokalemic, there is no contraindication to beginning with MRA even without having the other ones on board. So they're all not competitive with each other, but they complement each other, and we should all be aggressive in trying to bring them on board. So I think if there are any more comments here, I'm happy to have them.
So I think, Aparna, it's very important to understand that both ARNI as well as the MRA is going to increase the potassium. So when you're starting them, you don't start any drug in maximal doses. You start a combination of all 4 as much as possible, or at least 3 if possible, if not starting immediately on an SGLT2. Also look for postural hypotension and look for hyperkalemia once you start these patients on these group of drugs and worsening in eGFR. And simultaneously, it is very important to counsel the patient regarding the dietary sources of potassium, because a lot of our patients are very fond of Nimbu Pani and Nariyal Pani. So until you actually tell them that where the dietary sources of potassium are coming from, invariably the first week values that you will do after starting MRA, you will find that most patients do have hyperkalemia because the Indian diet per se is very, very high potassium diet. So until and unless you guide the patient on the potassium sources and where to cut down those potassium sources in the diet, a lot of people where you start an MRA, you might actually end up discontinuing after a week or 2 weeks because of hyperkalemia, wherein the baseline potassium was less than 5, but because you didn't counsel the patient ended up with a hyperkalemia. And especially a combination of ARNI or ARP with MRA is always invariably dicey in terms of starting together. So adding 1 week down the line each group of drugs, so that by 4 to 6 weeks you have all the drugs on board, makes better sense rather than starting them all together in one go.
Absolutely, absolutely. So you should have a 2-week difference between titration and addition, and you should try to aim in about 6 weeks to bring them all on board, even in small doses. And as she rightly said, we must check the potassium. And I think what point she mentioned was very pertinent. Potassium-rich diets should be looked into. We must tell our patients that they should not take. In India, I think Nariyal Pani is something which is really, and I recently had a patient came with a potassium of 5.5, and I was really surprised. He said, yeah, I take 2 glasses of Nariyal Pani every day. I was like, this is not fair. So I think that is a very valid point. And I think this was just to bring in that in HFrEF patients, we are well aware now that we have to have ARNI, and ARNI is preferred with a beta blocker, and of course aldosterone antagonist, SGLT2 inhibitor, diuretic, hydrolazine with isosulfide dinitrate. All the green boxes are class 1 indication. Ivabradine is a class 2A indication. For the want of time, I'm not going to delve into that. What is the foundational randomized trial which told us that this is a molecule which actually reduces cardiovascular morbidity and mortality? There were largely 2 trials. One was the RALS and the second was the FSS. So RALS was a trial which was done in patients who had severe heart failure. They were having left ventricular ejection fraction of less than or equal to 35%. A majority of patients in RALS were in NYHF functional class 3. And we realized that when it was in RALS, spironolactone was the molecule which is studied here. There was a 30% reduction in death. There were about 1,700 patients that were studied. The reduction in death in mortality was statistically significant in those patients who were given spironolactone versus placebo. It's very interesting to note that this was in 1999, and you will be impressed that when I actually looked up today to understand what was the proportion of patients in this trial that were on AC inhibitors, and it was resounding. This trial had 95% of patients in both arms on AC and ARBs or ARBs, but only 10% of patients in beta blockers. I think we've come a long way. We're doing much better. Our prescriptions have gotten better, but we have to understand that we have to have MRA because it was a RALS trial which told us, and it was halted prematurely. It was halted in 24 months because there was a statistically significant benefit in reduction of cardiovascular mortality and heart failure hospitalization in the arm which was given spironolactone compared to placebo. There was a sub-study done of RALS which tried to understand what is it unique in spironolactone that it reduces myocardial mortality and sudden cardiac death. So it was seen that, is it just aldosterone antagonism or is there something more to that? It was seen that when we give spironolactone, this PINP, PICP, IIINP basically are extracellular matrix turnover markers. It was noted that spironolactone actually reduces myocardial fibrosis, vascular fibrosis, and it has much benefits beyond just being a diuretic. So that was the reason that it reduces the extracellular matrix. And this came from this trial, and which led to the next trial, which is the Ephesus trial. It was a much larger trial. Now, Ephesus was done in patients who were post-MI, and they were post-MI with an ejection fraction of equal to or less than 40%. There were about 6,000 patients in this trial. And it showed that there was a significant, statistically significant reduction in cardiovascular mortality when patients who were given eplerenone versus placebo. Now, we don't have any head-to-head trial between spironolactone and eplerenone, but we do understand that eplerenone has higher sensitivity to the aldosterone receptors. We also understand that there are small studies which have told us that eplerenone actually changes the ejection fraction better and reduces the left ventricular end diastolic and systolic volumes better. So much so, in smaller studies, it has shown statistical significance. I think you will agree, most of us today, since eplerenone has gone off patent, most of us today give eplerenone to our patients because we also understand that spironolactone has this problem of gynecomastia. Amongst the trials and in clinical practice, we have understood that spironolactone gives rise to about 10% of patients having gynecomastia, while this specific adverse effect is much lesser with eplerenone. So if we open the question to the house, when do you want to prefer using eplerenone or spironolactone? Would you have any specific profile you may want to talk about? I think if anyone wants to, we are happy to take a question here, or else we can move on this.
I think the same issue that if you have a younger patient, especially a male younger patient, you don't want to use so much of spironolactone because of the painful gynecomastia, as well as in terms of the feminization features that the person complains of. So especially in young male HFrEF patients, I would prefer eplerenone rather than spironolactone.
Yes. Let me make a little point here. You made a very valid point that in the young, you don't want to give because it causes gynecomastia. So we had a patient who was actually staying in Pune, and this is about a year old. The patient was on spironolactone, and he was in Pune, and he went to his doctor. He went to his regular doctor, and he said that he has painful breasts, and the doctor palpated it and said, yes, there is an issue here. Now, this was an elderly patient who was on spironolactone. You have to believe this. It was thought that he has CA breast. He had FNAC done. He had a biopsy done. So, I mean, this is a very, very valid point, and we have to understand and keep at the back of our minds that the problem with spironolactone in 10 to 12% is significant gynecomastia. We know that the results are more resounding with eplerenone. Yes, the threshold for using spironolactone in the past was higher because of cost, but that issue has also been contained now with this molecule going off patent. I think we all agree that eplerenone is a superior molecule in terms of its efficacy, higher sensitivity to the aldosterone receptors, and of course doesn't have adverse effects like spironolactone. I think for this, I'll move on and have the answer sheet here as to what is the preferred dose and how is the titration carried out. So this is from the ESC guidelines, and this tells us for most of the molecules, I think we are well aware about ARNI, the starting dose and the target dose. We are well aware about the beta blockers, the SGLT2 inhibitors, and the MRA. I think what I want to just a little out of the curriculum, but yes, I wish to make a mention here that the uniqueness of SGLT2 is that the starting dose is a target dose. I'm very excited about that when I see that the starting dose is a target dose, because it is not true for any other classes when we are treating our patients of heart failure. So I really want to bring this molecule on board. When we're talking of MRA, the starting dose of both eplerenone and spironolactone is 25 milligram once daily. However, in spironolactone, some classes do mention, some guidelines do mention 12.5 to 25 milligram once daily. That's the starting dose. The target dose that we wish to achieve is 50 milligram once daily. I also want to make a mention here that when you are treating your patients and you have a patient and you think that, well, maybe I can go beyond this, it has been noted there has been no benefit that has been studied in patients if you give any of these drugs beyond the target dose. And how do we manage these patients and how do we manage hyperkalemia? I think this is a very nice chart which tells us as to how do we do it. So, in your patient, when you want to start spironolactone, the starting dose, as we mentioned, is 25 milligram once a day. Now, in those of your patients whose serum potassium is less than 4, surely you can increase the dose from 25 to 50 milligrams every day. You must remember in some of your patients, you may be prescribing spironolactone 25 milligram every other day. You can increase it to 25 milligram every day. In eplerenone, 25 milligram, you may want to increase it to 50 milligram when this patient's potassium is less than 4. And when the patient's potassium is between 4 and 5.4, there is no adjustment recommended because you have achieved what you wanted to. Now, here is the important point. As the patient's potassium begins to increase, you must escalate the dose of spironolactone and eplerenone. It's important to understand as the potassium increases, you don't have to stop the drug. You can make it every other day, unless the potassium is in dangerously higher levels, typically more than 5.5. We like to go slow. We would like to withdraw for a week, see how the patient is doing, reassess the potassium, and then reinitiate. But it may be a good idea if you achieve a potassium of 5, rather than going back on the dose, go to every other day, see how he's doing, and then you may want to increase it. We have understood, I think, just as gynecomastia, the prevalence of hyperkalemia has been studied from several trials. Both eplerenone and spironolactone together was about 10%, out of which 54% was truly MRA related. We understand that there are other causes for hyperkalemia, and let's just not blame this one molecule for it. I think we'll stop here and have the group come in. What in your practice, how do you see MRAs causing hyperkalemia, and have you required discontinuation of patients, and have you ever needed to think about using the potassium binders? I think it's important we talk about potassium binders here. So let's discuss a little about here. So I think anyone can come in here. And if we are not coming in, then I think I'll just spend a moment here on, I think we've already discussed that, and we will all agree that it's about, in our patients, in about 10% of patients do develop hyperkalemia. All of us as watchful clinicians do keep testing potassiums as they come back. I think a couple of things, we do KFT, we check a potassium, and we check blood pressure for all of our patients now in heart failure, because they are having molecules like ARNI on board, SGLT2, beta blockers, and MRAs. But what's important is How do we manage them? I think we just discussed, we reduce the dose of drug. I would like to make a mention here about potassium binders. I think you will be well aware that we already have one of them in the market by the trade name of K-Bind, but we have something which is not available in India yet, but is making rounds. That's called Patiromer. Now, Patiromer is there, and then we have another molecule called sodium zirconium cyclosilicate. So I'm not using it as much, but yes, there are these two. So you can argue that let us give ARNI, let us give MRA because we know they're beneficial, and also give Patiromer on top so potassium is controlled as a potassium binding agent. Well, this is not something that is recommended. Reason being, they have not been as yet studied in HFrEF patients, one. And in the small studies that they have been done, they have told us that these molecules, when added, do not allow us to escalate the GDMT to target doses. So we should be aware that we have potassium binding treatment available now, like Patiromer, like K-Bind. We have them, but we use them in a short term when we see hyperkalemia, but we don't use it on a long-term basis. The newer molecule Patiromer, I think it comes as Veltasa internationally. This molecule is not yet available in India, so we are not aware of it and we're not using it as much. But you should be aware that you don't want to use potassium binding agents. You want to titrate the dose of your MRA to reduce the potassium, titrate the dose of ARNI so the patient is not hyperkalemic, and that seems a better way forward. So I think this is a very important from the Ephesus trial, which tells us. So going back to Ephesus was a trial which was done in about a large number, about 6,000 patients, and of which 3,000 were given eplerenone and 3,000 were given placebo. All of these patients were post-MI, and they were started eplerenone 3 to 7 days post-MI. That was the randomization, to start within 3 to 7 days. Ejection fraction of 40% or lesser. So there was a sub-study which was saying, if you started eplerenone early, within 7 days, or if you started after 7 days, how did our patients behave? So it's clear that those of our patients, you can see from this bar, those of our patients who were started on eplerenone earlier, there was a significant reduction in all-cause mortality compared to those patients who were started later. The light gray bar is eplerenone, which was started later. Similarly, there was a reduction in sudden cardiac death in patients who were started eplerenone earlier within 7 days compared to those patients where it was started later, meaning thereby you should want to bring this molecule on board as quickly as you can, given the patient's potassium, GFR, and hemodynamics. If the GFR is less than 30, you would not want to give it. If the potassium is more than or equal to 5, you would not want to give it. If the creatinine is more than or equal to 2 to 2.5, you would not want to give it. If the patient's blood pressures are very fragile, you may not want to give it. Outside of this, you should want to give this molecule at the earliest so that your patients have improved outcomes in cardiovascular hospitalization and mortality. So in clinical practice, how early are MRAs initiated for management of heart failure patients? Let me take this question for the very first, and then I'll open the house. In our hospital, I don't think that MRAs are actually there as early as we want them to be. And I've been seeing in our clinical practice, and that's why I've called it an unsung hero, because we know the benefit of this molecule, yet we keep it far down. It could be because of the noise that is made by the industry with the newer kids on the block, and hence it is not given its due. I would like to open the house for discussion and seek your thoughts as to what do you think in your hospitals, in your clinical or in your cardiology practice which you see. Do you think MRAs actually have made their entry at the right time, or do they enter delayed?
The question actually is to be divided into two subparts. What patients you and I see in the hospital, most of them are hospitalized for heart failure, are in acute heart failure. They are wet patients. So they basically need loop diuretics or thiazide group of diuretics to decongest them. And that is the reason that probably MRAs take a backseat, because the hospitalized patients are not chronic heart failure, they are acute on chronic heart failure. And that's why the MRAs are not that much in picture in the hospitalized patient practice. Whereas in the OPD patients practice, yes, MRAs do figure in most of the prescriptions, either in combination with the other diuretics or standalone. But hospitalized patients, certainly the utilization is lower because of two challenges. One is in terms of the hyperkalemia, and the second is in terms of the fact that the patients are mostly wet and need to be diuresed quite aggressively initially.
Yeah, I think that's a very valid point that you bring in. And however, in continuation to what she said, we also have to understand that when we're giving loop diuretics, I'm always afraid what's happening to my patient's potassium. I, as an electrophysiologist, seeing large number of heart failure patients, I must confess we do see a large number of patients coming into the ER with ventricular tachycardias because of hypokalemia. So whenever we are discharging our patients, it's a good idea on discharge to have a look at the potassium. Consider initiation of an MRA along with loop diuretics, because you and I are much aware that loop diuretics are only to reduce morbidity. They are not going to change the patient's outcome. They have never shown to show any improvement in cardiovascular mortality. So you should want to educate the patient and be aware yourself that as time goes by, I will want to reduce the dose of loop diuretic and bring in MRAs.
They're not even part of the guidelines.
Absolutely. So that's what it is right here. That's where we are. So management of patients of HFrEF, we have to understand the foundational four: ARNI, inhibitors, beta blockers, MRA, SGLT2 inhibitors. And clearly, loop diuretic is only for fluid retention. When you see your patient has become dry, it's a good idea to get rid of this loop diuretic, because by doing so, it will allow you to up-titrate your doses of ARNI, up-titrate your dose of beta blockers. I don't want to go beyond, but as an electrophysiologist, I would certainly want to make a point that when you manage your patients of heart failure and you have given them guideline-directed medical therapy and you have watched them from 3 to 6 months, it's a good idea to consider, if the patient continues to remain symptomatic heart failure and have wide QRS, it's important to consider if your patient has a left bundle branch block and a QRS duration of more than 150, you should want to give the patient a CRT. If your patient has left bundle branch block with a QRS between 130 to 150, you should still want to give a CRT. It's a class 2A indication. In those of your patients who have a right bundle branch block with a QRS which is really wide, more than 150, it's a class 2A indication, making the case just clear here. Those of your patients who continue to remain symptomatic despite guideline-directed medical therapy, it's important to consider the implantation of cardiac resynchronization therapy devices. And those of your patients who have a narrow QRS but are an ischemic subset, you should want to consider, after 3 months of guideline-directed medical therapy, implantation of implantable cardioverter defibrillator. This slide is only to recapitulate and draw your attention again, the drugs in patients of HFrEF, AC inhibitors, however, ARNI is preferred to AC inhibitor, beta blocker, MRA, and SGLT2 inhibitors are all, from all the guidelines, their class of recommendation is class 1 with level of evidence A. Now, what happens to those of our patients whom we start an MRA and subsequently they withdraw the MRA and they do not want to take it because of, could be hyperkalemia or any other reason? There are smaller study, it's a small study though, it told us that patients who discontinued an MRA were more likely to be hospitalized or even have a cardiovascular mortality during follow-up compared to those who continued an MRA. The black big bar is those patients who were on MRA, while the gray is those who stopped. If you take all-cause hospitalization, cardiovascular hospitalization, or heart failure hospitalization, you can see the patients who were on MRA did much better than those who were on MRA but discontinued. Similar with the survival graph, the patients on MRA did much better compared to those who did not. I think this should be our last question, and we'll spend some time here discussing at what stage of heart failure diuretics and MRAs. I think Dr. Monica already spoke about this, but we can have more people from the house come in. And when you prefer a combination of eplerenone with torsemide, spironolactone with torsemide, so I think let's open the house to this question. So I think we can go back here. This question has already been much answered about diuretics and MRA. We have to understand that when we see our patients who are wet, we want to give them loop diuretics or thiazide diuretics. And when we see that they're beginning to get dry, we'd like to down titrate the dose of loop diuretics and bring MRAs on board. Now, again, it comes to the same thing. I mean, what is the preferred choice? We have all understood that. We have already realized that be it the aldosterone antagonism, be it the adverse side effects, be it improved outcomes, be it improvement in ejection fraction, reduction in LV end diastolic volumes and systolic volumes, we understand that eplerenone has an upper hand compared to spironolactone despite not having any head-to-head trial. And most of us have already learned that, and we are using at the outset a combination of eplerenone and a loop diuretic. But as time goes by, we want to get rid of the loop diuretic and bring on board the other molecules which allow us. I think in our practice, what are there any other indication apart from heart failure where MRAs are used? And I think this is the most important and pertinent. What more scientific initiatives would you suggest for CIPLA to take on for healthcare professionals to improve the awareness of this molecule? I think I'd really seek thoughts and opinion from key leaders like you to bring in here as to how do we increase the penetration of MRAs on the practice pad of our fellow colleagues and our own. Let's discuss that for the next, I think, few minutes before we close the house.
PCOS. A lot of MRAs and PCOS.
Yes, absolutely. So I think when you want to, we have to understand that why does it cause gynecomastia? It causes up titration of the estrogens. So I think we have to understand that we are using this in PCOS, as she rightly brought out. You may be, I don't know, aware, a lot of dermatologists use it for the treatment of acne in patients, in young girls. When they want to get rid of hirsutism, they give spironolactone. So MRAs do have their presence in other places also. And I think this is important. What more scientific initiatives can CIPLA do? I think what we are doing today is should have a ripple effect. And each one of us should take this and become a key opinion leader and open the house. And I think keep talking. The more we talk about it, the better we're going to get. We all realized in COVID, we learned so much from each other. I think one of the sessions I listened to Dr. Monica when she was talking of COVID. I think these are certain platforms where we all come together and learn from each other. So this is something which can be done, and let us all pledge that we talk more of this molecule. Each of us takes this forward, and we'll all be happy if there's something more that any of you wants to add on here. Sudhir, would you like to come in? And you have more ideas? I don't know, maybe in practice, maybe you could have more leafers. I've always believed this, that when patients of heart failure come into the hospital, that is the time that they're most vulnerable and they are most adept to suggestions. They don't want to come back again for a rehospitalization. That's a time where we like to educate our patients. I think it's a good point that you must have leafers. I mean, I always believe this. When you go to the United States, patients are well aware if he has LV dysfunction, needs a defibrillator. In our country, we are not yet there. Forget about defibrillator. I think it's important we educated them about their fluid management, told them about their lifestyles. CIPLA is a very big organization. If you could make some leafers where we educate our patients about their lifestyle managements, what is their fluid take, how they have to immunize themselves, what is their salt intake. You know, we tell patients, kam namak khaiye. What is kam namak? He doesn't understand what is kam namak. It's important you tell them what is a half teaspoon of salt in a day. How much NaCl does it contain? It's these simple things. A physician only has this much time and a bandwidth. So in my thought, CIPLA should take this on and have very nice pictorial graphs for patients. And on the other side, can have the names of foundational four where they must go back to their doctor and discuss it. So that's one way of educating the public at large. Let them know with leafers. And I seek more thoughts from the house if they have any more thoughts about this. Yeah, Ranjay, what are your thoughts? I think, do you think you agree with me that we can have these handouts and leafers? please unmute yourself. And it's nice to see you. We can't hear you. You'll have to unmute yourself.
Yeah, I fully agree with you, ma'am.
Yeah. I think he's well aware. I think he has a very large practice base that patients, when they come in heart failure into the emergency room, into the ICU, they're most vulnerable. They don't want to come back again to us. And that's the time that we really need to hit it large and give them education material before being discharged. I always tell them, read it in the hospital. And I actually have made a leaflet and I give it to the family and I tell them, stick it in their washroom. So when they are in the washroom, every morning they revise. What am I to do and what am I to not do? By doing so, I think it's a constant reminder to yourself, how much fluid am I to take? These are little things which we can, I think, incorporate in our daily life, in our clinical
practice. The challenge is that all the leaflets that you'll find will be in terms of the pacemakers and the CRT devices, because those are the companies that sell big, okay? I have at least not come across any decent leaflet on heart failure in India, either in English or in Hindi, because there is not much being done in terms of promoting these kind of leaflets by companies, whereas the companies which are selling devices will have leaflets lying in every OPD in cardiology in terms of what their devices are doing. You will not find any leaflet about potassium containing foods, about people who are on warfarin or acetrom as to what they are supposed to eat or not eat in terms of the salt intake in their diets, or in terms of management of a sick day in a heart failure. So I am thinking that what you're saying is absolutely right, in the sense that most of the leaflets that you'll find in the cardiology OPD are related to stents, devices, and pacemakers. I don't see anything happening other than that, because those are big money players.
Wonderful, Dr. Monica. And I could not say that you are so hit it on the point. If you permit me to share the screen, and if you can see this, can you see this which I have written here? So you see the screen, please?
Yes, ma'am, it's visible.
So this is
full screen.
Yeah, so this is what we have actually made for our hospital, and to every patient who goes discharged, we give these handouts to our patients in this colored format. I will be very happy to share it with anybody who wishes to use them with their own name and number, because we've already done intense amount of work on this. And you rightly said it, nobody wants to invest on this. So even for CIPLA, I think I'm very happy to share this even with CIPLA. And I've really worked hard making them. But this is something which should be given, and she's so true that none of the companies want to invest in this, which is so important. And I have made it very subtle, ejection fraction, because we got it made talking about ICDs, very subtle, talking about CRTs. In this subtlety, because you are not supposed to, patients should not unnecessarily ask for a therapy also. Similarly, we must educate our patients about medical management. So these are simple handouts. These handouts are the ones that we give to our patients from our hospital, ask them to put them on the back of their washroom, and it does help. I will think only 30% of them actually follow it, but I think it's worthy even if 30% follow. We'll soon achieve our goal.
We can provide you the in leaflet form, like in the as the diet chart they are providing in the diabetic patients. In the same way, we can provide you in the maximum OPD so that you can take the leaflet and the patient can carry it.
Yes.
Because maximum OPDs in the in the clinic and hospitals, they are not allowing us to paste there.
Absolutely. So Dhananjay, you will agree with me that we've been using these leaflets and how beneficial they are to our clinical practice.
Yeah, it must be. Even like many doctors don't know how much like salt should be used otherwise. So extra salt, always say we should avoid added salt in the form of achar, pepper, and chutney. But we don't know ourselves that how much salt like should be used otherwise practically.
You're right. I think Rohit, I mean, this program will really be worthy if we actually make an investment and do something like that, at least with few of us who are keen to do it. What do you think, Dr. Monica?
Certainly required. When you have diabetic diet charts and you have all sorts of pamphlets and leaflets lying around, why not?
Right. I think over to you, Rohit.
Yeah, thank you, ma'am. And thanks to all the participants, and thanks for your views. And definitely, CIPLA can do for the patient benefit. Very shortly, we are arranging this for your OPD purpose. You can utilize this booklet in your OPD, and the leaflets you can give to the patients, and that can definitely help the patient to understand better. And what we can do for the patient benefit, we can arrange it in the local languages so that they can understand better. Not only in English, we can provide it in Hindi also, or if required in some places, we can arrange for Punjabi or any other local languages also. So shortly, ma'am, we are arranging for your OPDs.
Thank you very much.
Thank you very much, ma'am, for giving us the attention on the patient benefit, and thank you for the wonderful interaction along with the expert panels closing the session on time, as we have started sharp at 8 o'clock. And for the benefit of all the cardio physicians, I think this session will really help their practice. And the role of Aplerenon, not only in the gynecomastia, definitely yes, in the role clarity is there of Aplerenon over spironolactone in the hyperkalemia. So as the early initiation of Aplerenon, we have with us, there's a brand of Ditor. Ditor T is there with the Aplerenon combination with us. And thank you for making us Ditor Plus as a big brand. We have spironolactone. In Ditor Plus, we have the low dose, as ma'am has pointed out, 25 milligram of spironolactone is required in heart failure cases. So we have with us with Ditor Plus LS also, with low dose of spironolactone 25. So thank you very much. Thank you for your kind attention during the session. Good night, ma'am. Good night.
Thank you so much. Thank you so much.
Good night. Enjoy it. Thank you.
Thank you. Rhythm team, we can wind up the session. Thank you, sir.